Good evening. Today my paper presentation is clinical study and microbiological evaluation of corneal ulcers in patients attending tertiary care hospital. I have no financial interest. Introduction. The cornea is a highly specialized part of the eye and its transparency is a requirement for good visual acuity. Corneal infections can damage the integrity of the ocular surface, thereby disturbing the transparency of the cornea, leading scars and decreasing visual acuity. According to WHO, infectious uveitis is the leading cause of corneal blindness in developing countries. Coming to the corneal ulceration, which results in 1.5 to 2 million new cases of the corneal blindness annually, posing a major public health problem. Fungi are the most common infectological agents, which account for 30 to 40%, which is the major chunk, whereas bacteria account for 13 to 48% of all spread keratitis. This varies by geographical area. These pathogens lead to the corneal damage directly or by release of toxins and enzymes or by activating the host immune system, and intact corneal epithelium acts as a barrier for the majority of the microorganisms which can penetrate through a breach in the epithelium followed by ocular trauma. Various risk factors have been implicated for increased incidence of the fungal keratitis, including injudicious use of antibiotics and steroids, use of contact lenses, and post-operative infections as well. Ocular morbidity such as corneal scarring and subsequent visual loss can be significantly reduced by prompt institution of the appropriate therapy guided by the knowledge of the causative agents. Aim of the study is to study distribution of keratitis in various subgroups of population of different age, sex, occupation, socioeconomic status to determine the distribution of keratitis in various presenting clinical forms of disease, predisposing risk factors, microbial profile, visual morbidity of the disease. Study design, it is a prospective study done in the Department of Ophthalmology, GGH Kakinada for 1 year in 50 patients. Inclusion criteria, all in clinically diagnosed corneal ulcer cases who have given consent. Exclusion criteria, all the non-infectious keratitis at PUK, VKC, Gordon's ulcers, everything is associated shield ulcer, contact lens related sterile infiltrate, marginal keratitis, interstitial keratitis, heteromatous were excluded. Cases of corneal ulcer which were presenting with the excessive corneal thinning and impending perforation as well perforated corneal ulcers were excluded, as taking corneal scraping was not feasible. Coming to results, age distribution, majority of the chunk is seen in 31 to 40 years and followed by 41 to 50 years. This is the representation of the age incidence. Gender distribution, majority is 86% is seen in male, followed by 40% in female. Predisposing factors coming to the ocular trauma, 40% is seen with the injury with vegetative matter, followed by 38% which is spontaneous, injury with foreign body is 22%. Occupational distribution, agricultural workers, 42% of agricultural workers seen, 26% is industrial workers, followed by others. Geographical percentage, rural people may constitute a major chunk of the percentage, 78%, followed by urban, which is 22%. Predisposing factors, ocular trauma, it is a major chunk, 62%, followed by non-traumatic factors, 38%. And location of the ulcer is important as well. Central location, it is 44%, peripherally 36%, both it is 20%. Coming to the microbial profile, 52% of cases are from fungi, 32% of cases from bacteria, parasitic it is nil, culture negative is 16%. Visual acuity time of presentation, 6.6 is nil, 6.9 to 6.18 is a 16, 6.24 to 6.60 is 20, less than 6.60 is a 14, and after the treatment, final visual acuity 6.6 it is 4 people, 6.9 to 6.18 is 18, 6.24 to 6.60 is 22, less than 6.60 is 6. These are the case of fungal corneal ulcer. This is the patient Adaparamba with the hypopion. Discussion, this clinical study was done in 50 patients with the corneal ulcer with the following observations. Out of 50 cases in this study, majority belongs to 30 to 50. Male to female ratio is 6:1. Males were more affected than females, probably due to more outdoor activity and more chances of exposure to contacts. Majority of seen in rural community, either agricultural laborers. Out of 50 cases, ocular trauma is the most common risk factor accounting for development of corneal ulcer. Among them, ocular trauma, which vegetative matter responsible for 40% cases. Central locations are more commonly seen. Majority of patients are presented with pain, redness, foreign body sensation, lacrimation, defective vision. Fungal keratitis is the more common than bacterial keratitis. Fusarium and aspergillus are the most common organisms isolated from fungal, and Staphylococcus aureus is the most common among bacteria. Visual acuity presentation, out of 50 it is 16% with visual acuity between 6.9 and 6.18, 20 with 6.24, 6.60, 14 with less than 6.60. Final visual outcome, it is more common between 6.9 and 6.18. Final visual outcome depends on the type of the lesion, virulence of the organism causing, and the host response to treatment. Conclusion: seborrheic keratitis is an avoidable vision-threatening disease that still represents the considerable proportion of daily new cases that creates huge burden on the resources of the health services. The clinical presentation of the bacterial and fungal corneal ulcers are often overlapping. Thus, confirmation by microbiological diagnosis is very essential in order to limit the ocular morbidity and prevent complications. Thank you.